In a large literature review study from 2019, they looking at the effects of the dementia severity and types of dementia and driving fitness. They looked at specifically Alzheimer's disease patients with very mild to moderate severe, and they looked at their driving assessment fail rates. And they found that those with very mild Alzheimer's dementia, they had about an on-the-road testing fail rate of about 13% in comparison to 1.6% of healthy controls without cognitive impairment, but were matched with age. Those with mild Alzheimer's dementia had about a 33% fail rate on those on-the-road testing. And driving patients who have mild or very mild Alzheimer's dementia have more turning errors than healthy drivers. They lose orientation, and they're more likely to endanger road safety. Next slide, please. With vascular dementia, it's a bit different than Alzheimer's because the ability of someone with vascular dementia to drive depends on the type of vascular dementia and the profile of vascular damage. So it really depends on where they had the vascular insult, what part of the brain was affected with ischemia, and how that affects someone's driving. So presents more diversely than someone with Alzheimer's. It's been shown that subcortical vascular dementia is associated with more constant progressive decline due to increasing gray matter atrophy and decreasing white matter integrity. In one study, they showed that patients with multi-infarct dementia showed poorer on-the-road driving safety than older patients with like things like diabetes or healthier older patients. So there was definitely a difference. In that literature review paper I mentioned in the last slide, where they looked at the different dementia types and severities and how that affects someone's driving, they found that about 70% of drivers with very mild and mild vascular dementia failed the on-the-road driving test, and compared to their healthy controls of 11%. Patients with a single stroke show poor driving performances, so about 46 of these patients do not pass the on-the-road driving assessment test. Next slide, please. So for frontotemporal dementia, the patients with this type of dementia show early unsafe behavioral symptoms, such as disinhibition, impulsivity, antisocial behavior, increased risk tolerance, which all severely impair the ability to drive safely and result in things like hit and run crashes, ignoring red lights, speeding, overlooking pedestrians, and oftentimes they misjudge distances, they are easily distracted, they ignore road signs or red traffic lights. It's actually suggested that patients who are diagnosed with frontotemporal dementia stop driving as soon as possible. There's the argument that depends on the subtype of the frontotemporal dementia. We know there's a behavioral subtype that has more of these behavioral symptoms, and there's also more of a semantic and verbal dysfunction subtype. So there's the thought that those who have more of the behavioral subtype of the frontotemporal should stop driving as soon as possible, but the thought that maybe those with more of the verbal or semantic subtype of frontotemporal dementia may be able to drive. But at the same time, you have to consider that someone with semantic memory or verbal dysfunctions may not be able to safely drive because they have difficulty with traffic sign comprehension, and they might not be able to get that information while they're driving. So in general, it's recommended that all those with frontotemporal dementia stop driving as soon as possible and get an assessment to assess if they are able to drive. Next slide, please. So with dementia with Lewy body, they typically show more cognitive deficits in attention, executive functioning, and visual perception that are even more severe than those with Alzheimer's. There's an association with fluctuation in attention, hallucinations, extrapyramidal symptoms. Of course, all of these things can affect someone's ability to drive. Both cognitive and non-cognitive symptoms severely impair driving skills in these patients in particular. In one study, patients with mild dementia of Lewy body showed poor performances in the healthy controls and all parameters of a driving simulation. And the on-the-road driving assessment fail rates were about 35 to 40% in the very mild and mild stages, compared to 11% in those who are healthy controls. Next slide, please. In Parkinson's disease dementia, cognitive symptoms include deficits in attention, executive functioning, and visual spatial. The difference with Parkinson's disease is even those who do not have dementia, they are at risk for being unsafe drivers because of the motor symptoms. About 18% of those who have Parkinson's disease with dementia pass the on-road driving assessment. So that means 82% do not pass the on-the-road driving assessment test. Next slide, please. So in this slide, I'm kind of summarizing that large literature review that looked at the dementia type and the dementia severity. So on the table in front of you, there's the etiology, which is the different etiology we just talked about, and the severity across the span of someone with dementia. So all the way from MCI to severe dementia. So overall, what they found was driving fitness was severely impaired in everyone who had moderate to severe dementia, regardless of the etiology. And they recommended that they do not drive. In those who had milder stages, they found that those that did not have Alzheimer's type, so everything aside from Alzheimer's, were at more increased risk for not being safe drivers. And that's because of the other behavioral and motor issues that happen with the other types of dementia that don't necessarily happen with Alzheimer's. With those with MCI and mild dementia, you can consider those with Alzheimer's type to maybe be able to drive as long as they're able to go through the on-the-road driving assessment. But overall, what they found was, regardless of the type of dementia, there was reduced driving fitness related to impaired attention, executive functioning, and visual spatial ability. Next slide, please. So just to go over the stages of dementia, I know I mentioned MCI, mild dementia, moderate, and severe. MCI not being dementia, just to clarify, MCI dementia meaning mild, moderate, severe, but MCI being something being cognitive impairment, but not dementia quite yet. There's the functional assessment scale, the FAST score that I like to use. That's based on the ADLs and IDLs to assess where someone's at in terms of their severity of dementia. There's also the clinical dementia rating score that you can use. In a 2015 systematic review, it was found that the CDR scale was the best predictor for evaluating driving safety in those with dementia. Drivers who had a CDR score of 0 were generally safe to drive, whereas those with CDR of 2 were unsafe. And those in between were intermediate in terms of safety, and they should be evaluated for driving safety. For those of you who do not use the CDR score, I have the link here for you. It's available here on the National Alzheimer's Coordinating Center. So what you do is you go through different cognitive domains, different skills, and you score where the patient's at in terms of impairment. And then it'll come up with a global score. It's kind of an average, and being from non-questionable, mild to moderate to severe. So again, someone with a CDR score of at least 2, which is moderate, the CDR score is telling us not to those patients are not safe to drive, whereas those with a CDR of 0 are probably safe to drive, and those in between should have more assessment. Next slide, please. For in the interest of time, this is actually a YouTube video that you can share with your patients and your family and their families or caregivers about specifically Alzheimer's and driving safety. It's about a minute in some seconds, so I don't think we have time. I'm not sure, Manal, if you wanted to share the video. Do we have time for it?
We can share it.
Okay, it's about a minute and 20 seconds. We want to share it. Is the audio on?
Can you not hear it?
I can hear it.
Let me see.
If not, it'll be available on the slide for everyone to be able to see it. Yeah, no audio.
Okay, I think we're going to skip it for now, but I will.
That's okay. That's okay. That's available on the slide for everyone if they want to take a look at it. It's something nice you can share with your patients and their loved ones about the importance of why, looking into driving cessation and those particularly Alzheimer's, but they also mentioned the other dementia types. Next slide, please. So with reporting, so in the state of California, we are mandated reporters for anyone who is diagnosed with dementia. So as soon as someone's diagnosed, you should file a report, send it to the DMV. Usually, like we had said, those with mild dementia, they can consider examination, driving safety knowledge test, and a driving test. And then they would, if they pass the drive safety knowledge test, which is a written test, and then they pass the on the road driving test, they would be re-examined every 6 to 12 months. And that's because mild dementia can rapidly progress to moderate and severe. So they would have to be checked pretty regularly. For moderate to severe dementia, they are unable to drive. Next slide, please. So I do want to mention, this is very important, what the implications of driving cessation are to our patients. And this is not just dementia patients, but every older patient that you find is an unsafe driver for whatever reason. And it's important to think about, you know, the ability for someone to drive is a huge milestone in someone's life. So when we all go through our driving test when we're younger and get our license, it's a milestone moment. And so it's also a milestone moment, an important transition in someone's life to stop that, to not be able to drive anymore. So it's something that really impacts someone's quality of life. So in a 2018 study that involved interviews and focus groups with patients as they were coping in this major transition of cessation to drive, they looked at different effects or impacts of driving cessation, and they found that there was a few of these I listed in front of you, including significant disruption and loss of identity, a loss of independence and autonomy, increased helplessness, increased depression, decreased socialization, poor general health, and a compromised doctor-patient relationship. And that last point is, I think, because unfortunately, as a medical provider, we are the ones who have to break the bad news to these patients and recommend that they stop driving. And of course, and we'll talk about in the next slide, but a lot of times they are resistant, or they become angry or upset or depressed because of this next stage in their life where they have to stop doing something they've done for many years. And I really like this quote that I got from this review study that summarized it quite nicely. So in the meaning of driving beyond how it contributes to survival, it is important in understudying the terms of its impact on well-being. So a lot of times we think it's just a transportation thing, but it's much more than that. People enjoy driving because of the scenery, to get away, you know, it's part of their identity, their ability to go and do things on their own, or just decide to go somewhere spontaneously. So it does affect someone's quality of life pretty significantly. Next slide, please. So in terms of communicating driving cessation to patients, it's always good to have a plan of action in terms of a kind of advanced planning of what we call driving retirement. So it's good to anticipate transportation needs for someone who will stop driving, and also recognize their emotions as they're going through this major transition in their life. They're going to, depending on your patient, will respond in certain different ways. So some will respond with anger or social withdrawal or resistance or denial. And this can also present a major barrier to accept the recommendation with those in dementia and those without dementia. And oftentimes, because the medical provider and the family are the ones to break the bad news, we end up being the people who get a lot of that negative response from the patient. It's good for patients to be aware that that there are driving evaluations that can help assess their driving their driving safety. So sometimes on the road driving evaluations are actually an effective way to convince someone of an older age that they may not be safe to drive. So sometimes they have to realize that they fail a test to realize that they should not be driving. Another strategy to use to kind of convince patients to stop driving is to remind them that once we deem them unfit to drive as medical providers, that there's many insurance companies that will refuse to pay for any damages if there is a collision or if there's an accident that they are at fault. I think a technique that I like to use, making this conversation a little more objective in terms of driving safety, it's either you pass or you fail, and trying to take some of the emotion out of it if we can. So some patients will say things like, you know, you're taking away my right to drive. And changing the perspective of driving a little bit and reminding them that it's a privilege, it's a unique privilege to be able to drive on the road. And it's a privilege that's only granted if you are able to pass the required testing. And if you don't pass it, you can't be safe to drive. So it's always good to kind of make it more objective, and if need be, kind of we have them go to the DMV and kind of go through the objective testing, so they're able to become aware that their driving is unsafe. Next slide, please. And so I'm going to briefly go over a case presentation. This is sort of the beginning. I don't really have a conclusion to it at this point, but I wanted to share a presentation of a patient of mine that has been in a similar situation as the other patients we're talking about. This is an 89-year-old male with hypertension, BPH, history of prostate cancer, who underwent a neuropsych evaluation and was diagnosed with mild dementia. At the time that he was diagnosed, he was reported to the DMV with mild dementia. On the right side of your screen is the actual copy of his report that we sent over. So we had said that he has a mental or emotional condition, and we specified mild dementia on a neuropsych evaluation. Next slide, please. So this patient established care with me after the neuropsych evaluation. So by the time I saw him in my clinic, he had already been reported to the DMV. And on 2 occasions, he told me about his frustration about being reported. He told me he had received a DMV letter about his driving evaluation. And every time he came to see me, I would always make sure that his family knew about the situation, that he should not be driving, and they always confirmed that he's not driving. In one particular appointment, 4 months after the neuropsych evaluation, he told me that he does not think he needs a test, that he's driving fine, but he has been listening to his family, he's not driving. And he did go through the written test twice, and he failed both times. And when he told me why that happened, he said, well, I was only given 8 days to prepare, and he felt that his wife was interrupting his study time, and that's why he failed the test twice. Next slide, please. So when I heard his responses and his rationalization of why he's not passing the test, I acknowledge his feelings. I tried to empathize as much as I could about what he's experiencing. He's very anxious about not being able to drive anymore. He was a very independent individual his entire life, and the fact that he's not going to be able to drive is severely affecting his quality of life. I tried to provide that perspective about that driving is a privilege, and that we should follow the rules in terms of the granting of those privileges. And I connected him also with transportation resources, him and his family, so they're prepared when he can't drive anymore. And I spoke to his daughter about it too. So I always brought in his daughter to be aware of our conversation, so they can reiterate these recommendations at home. This patient has mild dementia, but there's concern that he's not retaining a lot of information when I give it to him in clinic. So always pull in the family members to reiterate a lot of the recommendations, to remind patients, and to proactively take away the keys, make sure that that the patient does not have access to the car, so he's not able to drive without permission. Next slide. So this is a list of my resources for today's lecture. I thank you so much for your time, and I hope this lecture was helpful to go over driving and dementia. I'm happy to answer any questions.
Thank you, Dr. Deazambuja, for your wonderful presentation. So for anyone that might have any questions, please feel free to unmute yourself or put any questions in the chat.
Dr. Deazambuja, thank you. This was a great presentation. As you're informing DMV, do you also tell the patient that you're going to be sending a form to the DMV?
Yes, I usually do. I do inform them, and that's that I'm a mandatory reporter. I do tell them that we're going to send a report to the DMV.
See, and do you also inform the family if the family is not present?
Yes, yeah. So in this case with this patient, he would come by himself, but I would always call the daughter afterwards to let her know about the conversation.
Okay, thank you.
Any other questions? And again, please feel free to unmute yourself or put your questions in the chat. So there's a question. So when we diagnose someone with MCI, do we need to also send notification to the DMV?
No, that's a good question. For MCI, since there's not the functional, and Dr. Sagal, if you want to chime in, for MCI, no, there's no mandatory reporting. But dementia, because again, dementia has that functional impairment concern, then we're mandatory to report. For MCI, no. There's no mandatory reporting for MCI. Unless there's other reasons that the patient's driving unsafely on history or exam, but the diagnosis of MCI itself is not a required reason to report.
I agree with you, Dr. Dasenberg.
So if they have other reason, like based on their physical or based on the history of getting traffic tickets and such, do you refer them for a driving assessment?
Yes, if they have other reasons that, medical reasons, any transient loss of consciousness or any neurological conditions, yes, they should be assessed for driving safety.
And is this a situation you advise the patient to go get the assessment done, or do you report to DMV saying they need the assessment to be done?
You would, if it's something you're concerned about, you would report it to the DMV.
Thank you.
Any other questions? And again, please feel free to unmute yourself, put your questions in the chat.
Dr. Ambua, thank you so much
Yes.
for very detailed, background and even emotional and functional things. I have a questions. Some of my research participants, like person with Alzheimer, like he kind of really rigid to give up the driving. So even explain a lot, then is there any a little bit more advanced advice the family caregiver can, the request?
Yeah, and those cases are really difficult. I mean, I think physically taking away any ability for them to drive is going to be important. I know they're going through, they don't have the insight, they don't know what's going on around them, and to be there and empathize, because for them it's very confusing. They don't understand what's going on. But for the safety of everyone else on the road, definitely taking the keys away, making sure that they have no access to the car, and working closely with the caregivers. I mean, Alzheimer's Orange County has a really good educating classes for caregiving tips on what to do in those situations. So I would recommend going to like Alzheimer's or any of the associations where they educate caregivers on tips and tricks and how to like help our patients realize that they shouldn't be driving, but physically they should not have access to the keys. Again, they don't have insight what's going on. They don't know why they can't drive, but for the safety of that person and the safety of everyone else on the road, they should not be driving.
Thank you.
So last call for any other questions. And again, please feel free to unmute yourself or put it in the chat. Okay, so I think that is it for questions. So if you wish to receive CMEs, please fill out the form at the following link, or you can scan the QR code. We also ask that you complete the evaluation form, as this helps us with our continuous quality improvement efforts. This presentation and links will be sent out in a follow-up email before the end of the day, and I will also be sending out a link to last week's recording. Both of these forms will close at 11:59 on Tuesday, so please submit these as soon as you can. And also please join us next Friday, February 17th for office hours. So please bring any questions you might have regarding dementia, Alzheimer's, geriatrics, and we will have a clinician on the line to answer those questions. And I will be sending out a Zoom invite at the beginning of next week with more information. So thank you again for your time, and we hope to see you all at our office hours next Friday. So thank you again, Dr. Diaz-Mbuja, for your presentation.
Oh, thank you.
Thank you. Great job, Dr. Dasenberg.
Thank you.